Good afternoon, everyone, and welcome to our monthly CME offering offered by SHSU COM. I am Claire Collins. You've seen a lot of me in the last couple of months. We've been speaking a lot about adult learning over the last several months, and today we're going to wrap up our adult learning or our approaches to adult learning with part 4 of 4, where today we're going to talk about general versus differentiated instruction. So to kind of just dive right in with our session objectives, by the end of this session, attendees will be able to compare and contrast general instruction and differentiated instruction and kind of talk about what the differences between those two things are. You'll be able to apply the where to method in your own teaching, and you'll be able to employ aspects of differentiated instruction in your own learning environment. Now, before we kick off, one of the things that I want to do is really quickly recap what we've been learning over the last several months. So we've talked a lot about creating a good learning environment for students, holding them accountable, ways to adapt your own teaching and things like that. And so this piece is a nice kind of closer to all of those topics that we have been covering. Additionally, if you hear a little scratchiness in my throat, I want to apologize in advance. We've got a very high pollen level where I am right now. And as such, my voice is not what it normally is. So if you see me pause and take a drink of water, just hold with me and we'll work through this together. Okay, so to go ahead and dive right in. So the perception versus reality where students are concerned. One of the big preconceived notions about students is that every single student comes to us with the same level of ability. And the real truth is we tend to design the way we're going to teach students around this preconceived notion, right? Like if you assume that someone is going into 4th grade math, you would assume that they have at least base level mastery of 3rd grade mathematics. But if you live in the real world, you know that that's not necessarily true. And that extends into every single aspect of education, and medical education is certainly no different. So rather than saying that students come with the same level of ability, students come with their own inherent level of ability. And then the reality is every single student has unique needs and attitudes that helps them thrive in an educational environment. We've all seen that, right? Or taken part in those stories, or maybe you were a student that had a teacher that was really influential in your learning. And the way that they got through to you was they adapted their approach to teaching or explaining a concept in a way that was now clear to you. And that's kind of the base of differentiated learning. So I'm really excited that we're going to dive into this topic. It's kind of near and dear to my heart. And then one of the things I'd really like to say about differentiated learning is that accounting for differences in learners, treating students as individuals rather than as like a clump of learners, tends to add additional learning gains for all students involved. It's a net positive for the depth of instruction and the depth of the learning. And so we'll get a little bit into that a little later. So I'm going to be using the term general instruction a lot. And so it's important that we clarify kind of what is general instruction? What is that? So if you're thinking of general instruction, the easiest thing to think of is if you harken back to your own time in medical school, right? Most of your lectures were probably first straight up lectures where someone stood in the front of the room and they lectured for a solid hour, a solid 45 minutes, that without interruptions, without questions, and they just gave the information. There were some PowerPoint slides or projectors or whiteboards, and that was it. And you were expected to take your notes and learn from this interaction. And if you have questions, you're supposed to just go consult a textbook, right? That's one size fits all instruction. It is the most traditional form of instruction at every single level, at K-12, all the way up to medical education. I think residency is a bit of an outlier for this because residency education while there are didactics, there are fewer didactics, and it's more hands-on learning. So residency might be the exception to that. But generally speaking, it's also defined by this concept that your materials and approaches are developed for a large group. You're not taking into account the student who is colorblind, right? So if you're looking at biochemistry and you have everything labeled and there's various shades of blue and green, that's going to be pretty hard for someone who is colorblind to differentiate between those things. And you'll see differentiate comes up again. And that's not to say that you need to account for everything in your instruction, but being flexible and being open to changing the way that you're thinking about delivering concepts or material is really, really powerful. And while general instruction certainly has its place, in education, we talk a lot about this concept of the 80-20 rule, which is basically that we make 80% of our materials or 80% of our instructional design is geared towards 80% of the students. And as such, we're leaving about 20% without the support that they need. Now, that's fine from a continuous quality improvement standpoint. You can always stand to improve on 20%, and that's not a big gap. However, if you're talking about on the other end, 1/5 of your learners aren't having the best outcomes they could have, that's a lot of people. That's a lot of people, especially when you're starting to think about, hundreds of people in a classroom. To say that there's 100 students and 20 of them could be doing better if we just change things up, that really makes a case for adaptability and flexibility in your instructional design. But again, general instruction, there's little to no thought for differences in learners or their needs. And that's pretty standard. And one of the reasons for that really, right, is that one of our most precious commodities as educators or with working with students is time. And when you're talking about needing to create differentiated materials or approaches, that takes thought and reflection and time. And when time is so valuable and such a hard commodity to come by, sometimes that's what we sacrifice. We sacrifice that 20% because seeing to the needs of the 80% is really just the best we can do with what we're given. And I want to let you know that that's okay. Okay, so let's say that I'm someone who is utilizing general instruction. Is it bad? Absolutely not, right? We already covered this. It has its place in all aspects of education, including medical education. And one of the things people sometimes will talk about with general instruction is, why would I have differentiated instruction when especially medical students are all going to be responsible for passing the same board exams? Well, that's a great question. And the answer is this. Differentiated instruction and general instruction have nothing to do with performance on standardized tests. What it has to do with is this concept of everyone taking their own way to reach the same end goal. And sometimes that way is more challenging or difficult or takes a little longer, but everyone needs to get there at around the same time. One of the ways that is kind of a classic way to think about this is if you are taking a road trip, right? I am someone who likes to go from point A to point B the most direct route possible. But in my family, there is a big desire to go the most scenic route possible. And one of the reasons that irritates me is it is my perception that that route, because it is more meandering, is going to take longer. However, because we live in Texas, especially if I'm going to San Antonio from Houston, there's 2 Buc-ee's on the way and I want to stop there. And so I'm getting out of the car and I'm walking around for 15, 20 minutes 2 times. And so what tends to happen is that more meandering route that my family would like to take ends up being literally the same amount of time as the direct route that I want to take. And that's kind of the same logic we need to apply to performance on standardized tests. It's not so much about Is differentiated instruction going to detract from a student's overall ability to perform? The answer to that is no, because the ability to perform and the ability to be assessed is not the same as the student's ability to learn. Those are two different concepts. Instruction addresses learning, and it's not content specific. Okay, so you're going to use general instruction. What is like a best practice for that? Okay, assuming let's address the 80% first, and then let's get into differentiated instruction. So my favorite way to address general instruction is called backwards design. And it's by these two authors, Wiggins and McTeague, and they're my probably for instructional design and course design and curriculum design, really the best that there are. And based on all the awards they've won, it's pretty understood that professionally speaking, as far as professional practice is concerned, they are considered the best. And they've developed this method called the where to method. And it's how to develop an approach to teaching. It's not necessarily just about materials, because as preceptors, right, you're not going to be developing handouts usually for a student. That's the job of the course director. However, it's about developing like your attitudes and your perspectives on how to get the most out of this time that you have with your students. So it's a nice little acronym, and I like to think of it as like we're all getting on board this train on an educational journey, and we're in a cab, and what's the first thing any cabbie will ask you? Where to? So let's dive in. So the W in where to is how, and I'm literally going to read these to you all and then dive in a little deeper. So just know that. The W is how will you help your students know that they are headed, why they are going there, and what ways they will be evaluated along the way. So remember, in earlier adult learning theory, we talked about that adult learners are very motivated by the question of why. Why is this thing important? Why do I need to learn this? Why does this have practical applications? And then switching to what. So what am I going to be using for? What or how and what is being evaluated, and how am I being evaluated? With our medical students, we pretty much know that the way that they're being evaluated is through your feedback, which we had a session about giving constructive feedback. So if you haven't watched that one yet, go and look. It's on our YouTube channel. But we know that students are often being assessed or evaluated through standardized tests. So they actually know that answer, I would say 90% of the time. But if you have a way to, in your clinical teaching, work in why something they're learning is important. There are often times when you're explaining a process or a procedure where why this particular process or procedure over another is not well explained to a student. So remembering to verbalize kind of your thought process really helps students with their own clinical reasoning. And you'll see a lot of growth that way, because they'll start asking you questions about your logic and your thought process, and it will feel more like a colleague talking to you and having exploratory conversations rather than a student. So if you are willing to prep yourself to answer why questions, they won't be confrontational in nature, they'll be additive in nature. And hey, maybe there's the possibility even that in exploring these why questions, you'll discover that there is a method out there, a process out there, a procedure out there that is a new best practice that you aren't aware of and that you'd like to explore more. And that's not to say that what you initially chose is incorrect. That's just to say that there's always the opportunity to improve. So again, not controversial. The H, how will you hook and hold students' interest and enthusiasm through thought-provoking experiences at the beginning of each instructional episode? So one of the things that I have noticed working with preceptors and students, especially in a clinical environment, is that in residency, right, you do rounds, okay? That's your primer. That's the thing that's getting you hooked and excited for the day. These are the people you're going to be working with in theory, and then more to come. But that's your primer, and that's the thing that has you hooked. And this is your motivator for getting through the days, is those rounds. And they're educational in nature, right? We don't do that as much with students who are out on clinical rotations. And I think it's really a shame. And so, one of the things that I would tell you is that while it's not expected, if you're in a small clinic, right, it doesn't make sense to do grand rounds with a student. However, a 5 minute morning pre-brief or a 5 minute afternoon debrief working into the next day can be exceptionally additive to a student experience, because now they're keyed in on what is important to you throughout the day. You have had adequate time to explain what you need out of them for the day, and to make sure that y'all are both on the same page. And making sure and having that foundation is crucially important for both you and the student, to ensure that y'all have the best possible time with each other when you're talking about serving patients. And so that's the hook, right? Is that 5 morning debrief, or this pre-brief. The holding the student's interest, you should have really no interest in that, because they're going to be seeing a variety of patients. Variety is often the thing that will hold someone's interest. So don't worry about fulfilling that one too much. As far as E is concerned, what experiences will you provide to help students make their understandings real and equip all learners for success throughout your course or unit? So remember, I'm pulling these from Wiggins and McTeague directly. And so we're going to finesse that a little bit. Rather than a course or a unit, we're going to talk about your clinical rotation, or rotating through your service. So you may not know, and you probably don't know, some of the experiences that students are going to be having. But one of the things I encourage you to do is reflect back on your own experience as a learner to see what was most helpful for you. What were the questions that you wish you had had answered? One of the best ways to teach students well is to reflect back on the own gaps in your education or knowledge, and figure out ways to fill those with students. I will tell you honestly, students really respect that approach. It's a great approach to have. It shows that you're open to growth, you're open to change, you're acknowledging that there will be gaps at some point, and it's not your responsibility necessary to fill all of those gaps. But when you're talking about experiences, right? Let's say you're a preceptor and you're in surgery. Well, it stands to reason that a lot of the experiences that students will have are related to surgery. But being specific, does this mean that they will be handing you instruments? Does this mean that they will be helping with gloving and gowning? Does this mean that they'll be doing charts? How much patient interaction are they going to be having? Who handles that? That helps get you and a student on the same page. It makes sure that you are clear about your expectations, but then it also helps make sure that students aren't moving out of their scope of responsibility. Medical students are all eager to learn and to help and to do. And one of the things you always have to be careful of when working with medical students is that they are boxed in a little bit. Like, your expectation is you are to go up to this line and not cross it, because they won't know what that line is unless you're explicit and tell them what it is and where it is. So if you don't want them speaking to a patient, let's say you are on one of our medicine selectives, or you're in a 4th-year elective and you're an oncologist, I could see a scenario where you don't want a student speaking to a patient or their family. You want them to listen, because delivering that news is important to you, right? The way in which that information is delivered is important. And it is understandable that a 3rd-year or 4th-year medical student, not a resident, a medical student, would not have the training or insight in how to deliver such a sensitive message in a way that it can both be understood, but is also extremely compassionate. That's a learned skill, right? It's one that you've taken a lot of time to master. So setting that boundary with students, I'm a I'm a big proponent of setting healthy boundaries. So make sure that you do that. Set your boundaries where you need them, and then ensure that students are abiding by them. R, how will you cause students to reflect, revisit, revise, and rethink? Okay, this one's my favorite, and it's because it involves feedback, right? So when we think about these options, a lot of times we think about them in a negative context, right? Like things have gone wrong, so we need to reflect, revisit, revise, rethink. But they're also positive, correct? So if something goes really, really well, you want to reward students for having a good outcome or a good turnout. You want to encourage them to reflect back on what were the things that made this interaction really successful. How do you capture that energy, that moment in a bottle, so that you can have it over and over again? And the same is true with feedback, right? Negative feedback is getting students to be self-reflective as practice. It can be hard to do. So literally ask them to do that. I would like you to reflect upon the outcome that we had today and come to me later with ways that we could have improved this, or ways that we could communicate better so that we're not having similar issues next time. Or maybe it's just that your strategy needs to be revised. Maybe you set boundaries, like in the last piece that I talked to with E. Maybe you set boundaries and you realize, ooh, your boundaries are too narrow. You actually do need the students to be doing some things, and they're not, because you've been really firm. You can revise those boundaries or rethink them, right? At any point in time, it is up to you as the preceptor to determine what those boundaries are and how that learning is supposed to happen. And students will respect that as well. And it gives you a lot of flexibility as the instructor, as the preceptor, to make sure that students are getting the most out of that experience in a constructive way that makes sense for your clinical practice. Okay, the next E. How will students express their understandings and engage in meaningful self-evaluation? Okay, so in clinical settings, one of the things that happens a lot is trained physicians don't take a step back in a clinical setting to let a student step forward to express what they know or to articulate where gaps in their knowledge might be. So one of the things I'd like to encourage you all to do is to take a moment, usually 10, 15, maybe 30 seconds, to take a step back, either after working with the patient or while working with the patient, to check in with students so that they can express, yeah, I understand why we did this, or I don't understand why we did this, because identifying those gaps is really important. And there's this concept of when you are going to evaluate them, you evaluate them at the midpoint and at the end of their clinical rotations. And so those are more summative in nature, especially the one at the end. Summative meaning it takes everything into account. It's all the sum of all parts. Formative evaluation is about making corrections mid-course, so that there can be improvement, so that end-game outcomes are not necessarily negative. And so one of the things that I'd like to encourage you to do is engage in self-evaluation with students. Give them those opportunities to express that they don't understand a concept or they're good, let's move on. And the reason for that is, if it's formative in nature and you make a course correct halfway through, then that gives them half of a rotation to get better, to like actually get better. And that's a really, really nice thing. And it allows you as a preceptor to see that growth. And you can even talk about that growth when you're doing their final evaluation, right? That you made a midpoint correction, the student was already great, but they didn't understand this concept. And so you made a midpoint correction, the student was incredibly receptive, and you saw wonderful outcomes after that. That is great feedback. It's something that residency directors like to see, right? Like residency directors are always talking about how they don't really know how to use the clinical evaluations that get sent as part of the ERAS process. And some of that is because they tend to be very general in nature. However, if one of the things that you're displaying is that the student has the ability to take feedback and grow as a future physician from that feedback, that is phenomenal, right? Like if you're a residency director, that means you're bringing in someone that you know is ready to engage and ready to learn. And a lot of times that's one of the things you're looking for, or they kind of talk about that they're looking for, is that it's not necessarily about having the absolute best student, but having the best learner. And that is very, very different. And so that's one of the reasons why I wanted to talk to you all today about instruction and learning rather than assessment and knowing. That if we can help students learn how to learn, in the end, they're going to know all of the same things as everyone else, but they also have this skill now. And you have a skill, right? Like you know how to teach people how to learn. And it's great. Okay, so the T is how do you differentiate your instruction to address unique strengths and needs of every learner? So notice, even in general instruction, they talk about differentiation. Now, in this, they are this actual definition that Wiggins and McTeague have. It's a little more parsed down differentiation. It's really just saying, like, if you identify a gap in your learners, how are you going to adjust to meet that gap? That's what they're talking about. And so I don't want to spend a lot of time on T because we're going to talk about differentiation next. Okay, and the O finally is how will you organize learning experience so that students move from teacher-guided and concrete activities to independent applications that emphasize growing conceptual understandings as opposed to superficial coverage. Okay, so I love this one. If you are a preceptor and you're in a clinical setting, and on day one, you have the same relationship with your student as you do at the end of a 4-week rotation, that has not been meaningful, right? That there should be a shift. If you've ever thought about your own educational experience as a resident or as a medical student, one of the ways that you start seeing growth is people start out here, right? Like this is the student, or really this is the student back here. And this is the instructor. So this is your preceptor. This is you. And you're out front. And by the middle of the rotation, you should be about here. Not in knowledge, right? Not in ability, not in strength, but an ability to trust in each other and the ability to achieve end goals and communicate well with each other. And then you should move the student forward. Let the student take the lead on some things, if you can trust them. And so building that trust, having the ability to have that trust is one of the ways that you can ensure that students are showing that they have these broad conceptual understandings as opposed to superficial coverage. If you never allow the students to directly engage with patients, they never have a way to actually display that they have a deep, like kind of resonant understanding of what's going on in a clinical scenario. And I think that that's one of the key differences between like precepting and shadowing, right? Like, so shadowing, even if a student is shadowing you for a long time, they're not allowed to have patient interactions. They're really there to just sit in the background and watch what you do, because what they're trying to get a sense of is, how do you spend your time? How do you spend your day? What do you do with your time? What do patient interactions look like? What does the workload look like? There's a little bit of that in being a preceptor, sure, because the students are having exposure. So of course they're forming opinions, but they're actually there to learn, like, how do you actually do this thing? Like, what does it mean to be an internal medicine doc? And like, what are the approaches or what are the, diagnoses that get rendered the most often? Or what are the frustrations that people have with EMRs or EHRs? That's important to student learning. But if you always keep them at arm's distance and treat it more like shadowing, where the student kind of lurks in the background, they'll never actually learn. Well, they'll learn some, but they won't ever get a chance to display to you that learning has occurred. And that's one of the key indicators of success in any student-teacher relationship, is that the teacher, the instructor instructs and relays knowledge and ability, but then is asking students to demonstrate understanding. So if you never make that switch, that would be a bad thing. So just know that in the back of your mind, it might help you to have a conversation with students to say, my expectation is that when we start doing our rotations together, is that you will be mostly in the background. But at the end of 4 weeks, I'd like you to be mostly in the forefront. That's great. That's fantastic. And of course, I'm not going to say that students should be mostly in the forefront all the time, right? Like if you have a complex case coming in, of course, the student should be in the forefront of that. Like use your best judgment. But you want to provide opportunities for students to kind of show off what they've learned in meaningful ways for both you and them. Because how are you going to assess it otherwise? How are you going to truly assess it if they're just there to be quiet? Okay, so we've talked a little bit about general instruction. So now I want to move on to differentiated instruction, which is what we're kind of here today to talk about. So differentiated instruction is considered the gold standard of educational instruction. And the reason for that is it sees to the needs of every single individual learner. So it is that learners still have to meet all the same standards of knowing, but they take a different route to get there. Remember I said there's that map kind of thing where it's like the most direct route and the winding route. We're both going to get there probably pretty close to the same time. We just took different routes because for some reason in my family, it's important that they go see all the pretty trees. And me, I'm like, I just want to go as fast as possible. So I need an open stretch of road and a highway, and I need a car that'll go, I'll say the speed limit, or a little above. But differentiated instruction accounts for those differences. So it says, if you're someone who's in the fast lane, get in the fast lane. If you're someone who wants to take that scenic route, let's take the scenic route. And I'll put some stops along the way that are going to be important for you both, and I'll adapt. So let's get into how to make differentiated instruction successful. So this is it. Okay, this one slide to talk about differentiated instruction. The first thing is to just watch the students. This is especially important in clinical settings where you have skills that are being performed. So a student is, I don't know why a student would actually be taking a chest x-ray, but let's say that there's some scenario where they are and you notice that they're doing it incorrectly, making an adjustment to that. Or you notice that a student is struggling to work in surgery and it's because of their height, right? Watching students and doing something that's differentiated is sometimes about accommodations. And sometimes when I say the word accommodations, people groan. They're like, listen, I don't have time to make an accommodation for someone. But one of the things I would tell you is left-handed people exist. That's what I always use, is that, there's always more than one way to do something and do it the right way, and to do it the same way, but in a reverse order or flipped around. And that's because left-handed people exist, right? So just watch for things that might ease the learning for the students and help them cover any gaps that they or you might see. And then listen. So sometimes when you're listening to students kind of recount what's been happening for the day, you'll get a sense that they actually don't have a very good understanding of what's going on. And that's pretty normal, right? These are third-year medical students. They're not residents. They haven't been in practice for 20 years type thing. And when you listen to a student, a lot of times they'll start telling you what their needs are. Oh, I wish there was a journal article about this. Oh, I wish there was a way that I could see more of these. Oh, I wish there was a. And so, in that instance, listening is you helping align students with resources. It's not necessarily taking any more time out of your day, because the assumption is you probably already know where you would go if you were struggling, if you wanted resources. For instance, you might just say, oh, there's this doc that I watch on YouTube that has some really great approaches to this same technique. Go out and watch X, Y, and Z video, or you just text them a link from your phone, right? That is perfectly normal. Or you might say, well, there actually is a journal article about this. If you go out on, PubMed, you can go ahead and pull it and then read up on this. And actually, my expectation is that you go ahead and do that before tomorrow. That's normal, right? That's just getting students aligned with resources. That's not making an accommodation. That's just covering for gaps. But also students will say things like, I wish when we were together, I could see things more clearly. Because one of the things I've noticed, especially in like a small rural setting, is if you're in a clinic, is that the student will literally be behind the preceptor, like literally behind them. And so you're talking to the patient, they're looking at your back. And so inviting students to be an active part of that learning environment is really, really powerful, and is kind of a best practice. But you'll have to remember that sometimes students won't do it naturally. Medical students tend to have a very high level of deference to their preceptors. So they often kind of go out of their way to take up as little space as possible. And sometimes that means being out of your line of sight. So just inviting them in can be really, really, really great. So then the next piece I would give you is just be okay with adapting. You might have in your mind, especially if you've done clinical teaching before, that you have a method that you use. You always have a set. Like I've worked with someone before who had a really set, like 2 minutes before they go in to talk to a patient, they talk to their student that's on their clinical rotation, and then they go in and they work with their patient and they do all this stuff, and then they come out and for 2 minutes they kind of quiz the student on what was going on, and then they have the students write the notes. That may not work for every student. It might be, again, that general instruction. It might cover 80% of the students, but what are you going to do with the 20% of students who don't know what to expect during the pre-brief? If it's something they've never seen before, they'll have probably heard of it, but if it's something they're not intimately familiar with, if it's, flesh-eating bacteria, I could see a student having a lot of questions before ever stepping in the room, and you as an instructor may not have time to answer those questions in that format. So you're already breaking down kind of your standard operating procedure. You have to be okay with adapting on the fly. You do it in your clinical practice all the time with your patients, and so you have to do that as well with your clinical teaching. Being an adaptive instructor is actually one of the most powerful tools in your tool belt. And you also, when you're doing adaptation, one of the things you have to go into it knowing is not every adaptation is going to be successful. Sometimes you're going to adapt on the fly and it's just going to fall flat. You'll still have a good patient outcome, but your learning experience didn't improve any. And that is okay as well. That is normal as well. And just know that there's no expectation that every single learning scenario, every single clinical teaching opportunity is going to be a raging success. And that's because there's just an understanding that there are going to be gaps in your ability to teach, and there's also going to be gaps in the student's ability to learn. But as long as we acknowledge that those gaps are there, you can adapt and overcome. The next thing is you just want to encourage students, encourage them to ask questions, encourage them, I said, watching and listening, encourage them to ask for the things that they need, encourage them to allow spaces and reminders that you need to be watching them, and that they should be making that change into the forefront of a patient interaction. That's really, really important for the success of these learners. And then correct, right? Differentiated instruction, just like general instruction, allows for a lot of room to correct students. When you think about general instruction, right, when you're thinking of that 80-20 rule, because you don't have the ability to adapt much, you also don't have the ability to make a course correction if you should need it. But differentiated instruction allows you to make a correction, either a self-correction, which is wild sometimes to me, or to correct a student. And so when I say that it's wild to me that you would be able to do a self-correct, is I love that in differentiated learning, because you meld your teaching style to the learning style of the student, it allows you to make corrections along the way and assume that you've probably gotten a lot of it wrong. And that's okay, because as you become more and more aligned with what works for that student, you start seeing these bigger leaps in their knowledge and their ability. It's really extremely rewarding. So that's what I would say, is that when you're talking about teaching, there's always a perception in medical education that students need to meet us where we are. No, it's the opposite. We need to meet them where they are in their abilities. Because if we expect them to meet us where we are, we're experts, right? So we've got 10 years or 20 years or 30 years or 40 years in some instances of training under our belts that taught us how to do these things, and shaped us into the experts that we are. Students do not have that, so they cannot cover such a big gap. However, because instructors have been those students before, going back and meeting them is way, way easier. I mean, think of it like a mountain, right? It is always easier to go, well, maybe not a mountain. I was thinking Everest in my mind. I was like, I don't know if going down Everest is actually easier than going up. But let's say a hill, like a standard hill, a big hill. It is always easier to go down the hill than it is to go up the hill, right? That's one of the reasons that we like getting over a hill. It's like, once you're over that hump, it's easier. It's easier on your body in a lot of ways, unless the hill's really steep. But it's just, gravity propels you down. So it's always easier to turn around and figure out where the gaps are with the student than it is for you to expect the student to make a big leap on their own. The next thing I would say is just be reflective. I don't mean anything big, like you don't have to keep a journal or anything like that, not unless you want to. But as you're getting ready for the day, reflect on what you want to get out of this student-teacher relationship, this student preceptor relationship. Reflect on the things that went well the day before. Reflect on the things that didn't go well before. It does not take a lot of time to be reflective. Really, truly, you're talking maybe 3 minutes a day, 4 minutes a day. If you're working downtown at the medical center, right, and you have to park and then you have to walk, you can be reflective on your walk. There's plenty of time to always be reflective. And what that reflection allows you to do is segue into our next topic, which is take action. One of the things that I think happens a lot is that preceptors or people who are in a clinical setting, they don't take action after they've reflected. They reflected and they've identified that there's a strength or a weakness, but they do nothing to say, let's bridge that gap, or let's reinforce good behavior. A lot of times we're just reflecting for the sake of reflecting. It ends up being more of like a mental health exercise than anything else. And that's doing a disservice to both you and to your learners. So just remember that as you're reflecting, if you don't make a plan to take any action, then you're letting yourself down. And that learning, it doesn't mean that you have an unsuccessful relationship with your student, or a poor instructor. It just means that relationship could be stronger. So if you're someone who's doing motivated, I'm very doing motivated. I want to get things done. I really want a fast clip, in all of the work that I do. One of the things I have to remind myself to do is to slow down and reflect on what my end goals are, what positive outcomes are, what I'm wanting from certain things, or relationships, or people, or even software that I work with. Like, what do I actually want? But I don't struggle with taking action. However, a lot of people are the reverse. They reflect well. They think things through. They, people mull. Have you ever met a muller? Someone who just wants to think things through until the cows come home. If you're a muller, you have to remember to take action. You have to remember that you're there to get things done. And if you're not taking action, you haven't completed this cycle. And so what does taking action look like in a clinical setting? So taking action can be something as simple as just literally communicating to the student, hey, this went really well. Thank you for that. Continue doing that. Or this didn't go well. And here's why. These are the adjustments that need to be made. And I need to ensure that this doesn't happen again. Be direct. Remember, we talked in the last feedback, giving valuable feedback, that students actually kind of value directness. Like, there's this concept that people want a feedback sandwich where it's like something positive, something maybe negative, and then something positive. No, the literature has kind of blown that out of the water where clinical teaching is involved, that both preceptors find it annoying and students are like, they're just waiting to hear the negative, right? So sometimes it's easier to start with the negative and then go with the positives, or you just start with the positives and go into the negatives and like kind of go down the list. That's fine. But you don't need to have like a really huge approach, or really like really intentional approach to that feedback but just tell them like it is. Be kind about it, be nice, but just tell it like it is. But take that action. And sometimes the action might be, right, like we talked earlier about the watch and the listen. In the instance of the student who is too short to participate in the surgery area, maybe that's just getting them a stool to stand on. Maybe that's lowering the surgical field, like moving the table down, whatever works. But if a stool is all it takes, it's easy enough to get one, right? Take action, put things into motion. And then finally, differentiated instruction. The most successful versions of it are the ones where faculty are getting students on your team. And what I mean by that is this: tell them you're doing these things. Tell them that you're adapting. Tell them you mean to encourage them. Tell them that you're going to be correcting them. Tell them that they need to be reflecting. Tell them to take action, or that you're going to take action, or to remind you to take action. If you integrate the student into their differentiated instruction and ask them, like, so tell me what's working for you. Tell me what's not. So when we're doing evaluations here at the COM, sometimes we literally just send 2 questions. What's working? What isn't? Because it's a direct question, right? It's super direct. What's working? What isn't? Ask the student that. That lets them own their own education and be really open to the idea of that you want this to be something that is a really successful endeavor for them, that you're on their team. So as long as you do that, as long as you're kind of following those general guidelines, then differentiated instruction will be wildly successful for you. And remember that differentiated instruction is not really all about sucking up all of your time and treating students so differently that you can't get any work done. It's about allowing for adaptation in the way information is relayed, or materials are produced, or learning happens, so that students have a deeper understanding of what you're trying to teach, so that they can learn and obtain knowledge at a faster rate. And if you're into differentiated instruction, you want more ideas about differentiated instruction, you are always free to reach out to me. Please do. If you're finding that you have students and you aren't sure how to like make that leap with them, it is perfectly acceptable for you to give me a call or shoot me an email, and we can walk through approaches that you can take in your own clinical practice. That's my offer to you. Or if you want to invite me out, I'm happy to drive to you. We have partners all over Texas and a couple in Louisiana. And if you want me to drive out to Louisiana, I'm more than happy to come. But that is all we have for today on the topic of differentiated instruction and general instruction. And I hope that you enjoyed this time with us today. And let me put in the chat, if you have questions, you are free to put them in the chat or in the Q&A. Let me put the link to our handy dandy Qualtrics survey. You'll need to take this so that you can get your CME credit. But if there aren't any questions, I want to thank you so much for your time and attention today. And as always, we will see you next month. Okay, have a good one.